Hello, everyone, and welcome to another episode of Medicine in Small Doses with Dr. Amobi. As you know, I'm your host, Dr. Amobi, and today I'm genuinely excited to be joined by a remarkable guest, in my estimation, someone I uniquely had the privilege of meeting. I will start this interview by going through a bit of how I met Dr. Loretta, who we're going to talk about a bit more in detail. You see, a little while ago, I think that was about last year, I was invited to give a keynote speech at a women's event in Manchester, England. You see, one of the things that Black people in the UK do is we invite the best of the best to come and give talks to our community in order to uplift us as we go along. So I was giving a talk on menopause and its impact on Black women. The event was organized with meticulous care and attention to detail. Everything ran so smoothly, and the audience walked away with valuable insights. Our chief host for that event was none other than our today's guest, Dr. Loretta. The feedback we got that day was extraordinary. The event was overwhelmingly positive. The testimonial we get was extraordinary, which shows her leadership and her dedication towards particularly the Black people's health, not only just in the United Kingdom, but also Africa and across the nation. So, and today we had the opportunity to have her here on our podcast, discussing her incredible journey in gynecology and obstetrics and her aspiration as an aspiring governor of Edo State in Nigeria. So the theme today is about from gynecology to a governor. So Dr. Loretta, having you here today, as always, is a passion and it's a pleasure. Please, I would like you to normally I introduce my guests, but today I'm going to do it a little bit different. I would like you actually to introduce yourself to our listeners and tell us more about your background and your mission.
Thank you very much, Dr. Amobi. Good evening, everyone listening, and to all those who will eventually listen to this. My name is Loretta, Dr. Loretta Oduware Ogbo Oko, and the last name is a compound name made up of both my father's name and my husband's name. I am from, yes, you've said that, I'm from Edo State in Nigeria. Migrated to the United Kingdom in 2005 after I completed my NYSC program following studying medicine at the University of Benin and doing my houseman year and then the 1 year mandatory service to our nation in Nigeria called the NYSC. So I came in and did a master's in public health research and then eventually got into the training program. I did my residency, what you call the specialty training in the UK, and then became a consultant obstetrician and gynecologist. So that means the doctors who look after pregnant and non-pregnant women. And sometimes we look after their partners, depending on what brings them in. And sometimes we look after the babies when they are born as well. So we are a unique specialty. We sit right there at the core of all things that evolve around humanity. That's how I see my specialty. But along the line, I have done a number of things. Like I've mentioned, I've done research. I actually did an MS in clinical education. So you find that I do a lot of work in medical education and simulation. So I run simulation courses with our trusts, previous trusts. And then, of course, I didn't stop there. I found that a lot of migrant population, like the Black and ethnic minority, they have a lot of things that are burdens because of the intersections of these actual population. And what did we find? We found out that there are long-term gynecological implications of one being illegally trafficked or coming into host countries. So I'm doing a PhD now in law and criminology with special emphasis on trafficking and contemporary slavery. So apart from core career side, I've always been somebody who has done a number of things across board that when people ask me, what do you do? I just smile because I seem to have dabbled into everything. I'm an author. I've written 2 books published on Amazon. A third one was recently launched in New York, where I was co-author. So I'm author of the book My Father's Daughter and Heartwebs, and now Global Integral Beauty. I also am someone who has been very entrenched in community work, humanitarian work, across borders, nationally and otherwise. So you find that I worked for the UN at some time. I'm a United Nations eminent ambassador. I'm a global goodwill ambassador. And I've always worked in the grassroots, which is where you and I met at the Caribbean and African Health Networking event on Women's Day last year. And your speech was simply fantastic in a very topical issue where our communities sometimes don't really want to talk about them because of our own social cultural fabric. But by and large, I've taken it up to policy level because I've always understood that to make massive changes in population, one has to do it at proper policy level. So that's why I am foraying into politics. And I'm right now running to be candidate of the Labour Party, running for governor of Edo State in 2024. Because the truth is, what we migrants do all over the world, irrespective of the country we are in, the host or the source nations, as we will call it, irrespective of where these are, we can actually replicate them at home if we have the right policies, the right environment, the proper drivers, and bottom line, governance that has value for human life. So, in a nutshell, that's about me. I have my obstetrics and gynecology, which I love, and I do all these other things in the background. And I'm blessed with a very lovely family, married to a consultant neurosurgeon with 2 beautiful children.
Yeah, that was amazing, and that's why I wanted people to hear from you directly, because I don't think I'll do it as much justice, because I know what you've done. We had a lot of conversation. I would say 99% of the talks that we had is always, centered on health, on how to help people back home. And I think one of the things that stood out for me the day we met was an invited guest was given a statistic on maternal death. And their statistic was based on the UK stats, right? And they said the black women are 2 or 4 times. You go, no, actually, it's not 2 or 4 times. It's way higher than that, and very passionately. And that's when I said, look, I'm going to have to invite you to podcast, because the passion, not only the way you govern the whole, arena that day, so many people, one of the interesting things, because it's a combination thing between the Caribbean and the Africans, right? And you came that day, you wore, your proper Nigerian attire, everybody, all the Caribbean people who were there actually learned about Edo State. That was the first, they were like, wow, that is a flamboyant dress. That's beautiful. And you explaining to everybody how this is your culture. This is how you just like, I think about 4 or 5 outfits of Edo State showed up that day. So you wore your state like, as proudly as anybody. And I think you're just about the only person who wore like the real traditional attire that day. So that was amazing. And so when we talked about, maternal death and things like that, one of the things I want to point out to you is like the statistic from the World Health Organization, which of course paints like a very, deeply concerning picture about, maternal mortality, health of our mothers in Nigeria, for example. So as of 2020, Nigeria has one of the highest maternal mortality rates in the world. So with about 1,047 deaths per 100,000. And the reason I'm giving you this stat is that it was on when somebody was saying about black women in the UK are 2 to 4 times more likely to die than every other race, that you corrected them. And you reflected as well that we need to do more about people in Nigeria because their statistics are worse. And that's what prompted me to look a bit more deeply into this stats. right? So for me, it's quite difficult to comprehend that nearly 20% of all global deaths, that occur in pregnant women or women who just given birth occur actually only in Nigeria. That's like 20%. That's huge, you know. And the lifetime risk of, for Nigerian women is equally alarming as like 1 in 22 when you compare it to 1 in 4,900 in most developed countries. So and like you rightly put in one of your talks, you said these are not just numbers, they represent our sisters, our friends, our relatives, our colleagues. So it's a sobering reality that, close to home, for many of us. But I would like to hear your thoughts on these statistics and what drives you to make the change that we so critically needed in the healthcare system of Nigeria. And hopefully Edo State will be the flag bearer for that.
Thank you very much. It's not just surreal. It's really, really saddening. It is abysmal.
Mhm.
And like you noticed that day, when these figures are being quoted in conference halls across the world where I attend, I feel really, really sad that our countries are first from the bottom or second from the bottom in things that are negative. They shouldn't be. A maternal death in the United Kingdom is a never event. And you find that it is audited by the Embrace and Embrace report and even the Royal College of Obs and Gynae and all of that. Even the hospital themselves will always put in auditing trails. Why did it happen? How can we make it not happen again? How can we do better? So for me, each time I sit in these audiences, I don't know about other people, but I feel really, really sad. And I
Mhm.
feel sad because I've come to realize that it's not rocket science to fix these things. Personally, I do not believe that any woman should die in the course of her reproductive duties. And I agree that that should be a never event. And you've quoted these statistics. People think, oh, they are numbers. But these are human beings. These are women who have husbands. They have other children. They have mothers, brothers. They have, in fact, you're looking at a whole village. For each woman, you're actually looking at a whole village. And I like that you quoted the WHO statistics, and you actually have told us that WHO is saying about 1,047 are dying per 100,000 live births in Nigeria. When you say it that way, it doesn't hit home. Because I took my pen and I did the calculation and narrowed it down. And I can tell you that when you break it down, my dear Dr. Amobi, and to the listeners, you find out that an average of 150 women die every day in the course of their reproductive duties, from pregnancy, antenatal, labor, and pregnancy-related issues. 150 women every day. And look at this against a backdrop where we don't have adequate data. A lot of the things that WHO is working with is estimates. So imagine if we had the true picture, 150, what would that be like? So it's really, really sad. And those states in Nigeria is not removed from what is happening. It's a state in Nigeria, so it's representative. The maternal mortality in these places is high and appalling. What do we do to stem the tide? What we must first do is to understand that healthcare as a whole needs to be in the front burner in both the national level and the sub-national government level, which is at state level. And to achieve this, we must go to the grassroots level, which in Nigeria is the equivalent of the local government, and fix our primary health care. Now, in the UK, that's the equivalent of the GPs that we have. Yeah. So we need to go back, because any healthcare system, what it solves, must be primary healthcare heavy. So it's like a pyramid. At the bottom of that pyramid, which is the base, you have where the majority of the population go to, and that should be that they are going for primary health care, where they are taken care of. Blood pressure is checked, diabetes checks are run, basic illnesses are seen, people are being seen. The WHO recommendation of about one doctor to 600 patients is happening, and then they refer on to secondary care, and secondary care pushes on to tertiary care, which is exactly what happens in the UK. People go see their GP, they treat you. If it's beyond them, they refer you to the specialist. And that's when you come to people like myself in the hospital, depending on what is wrong with you. I'm sure Dr. Amobi, you can corroborate that. If they think it's a urology thing, they send you. If it's an obstetric and gynecology thing, they send you. Now, what you find out in resource-poor nations is that there is no care at the base of the pyramid that is effective. Nigeria has about 133 million persons. Edo State has about 5 million population estimated. Of that 133, Nigeria has about 200 million people, plus and counting. And Edo State has a population of about 5 million. Now, what I'm saying is that these 200 million people and these 5 million people are part of these 200 million people, and they don't have primary health care. There's no facility to be seen at that local government level, because even the local governments are not functional. They're not working, and they are closest to the roots. So you find out that education and health is deficient. And these are two sides of the same coin. We must bring these things to the front burner. We must ensure that the Abuja Declaration that was done in Abuja, where they say we must devote 15% of national budget in African countries to healthcare, must be actualized. We are not doing that. At the national level, our budget for healthcare is abysmal. It's a meager about 6%. At the state level, it's the same thing. Then you find that people are spending billions of naira on entertaining guests in government houses. Or they'll tell you that they spent a lot of money, hosting certain events. So that needs to be tackled. Healthcare, first of all, needs to have adequate budgeting, number one. Number two, it needs to be brought to the grassroots. It needs to be brought to the people. So local government must begin to function. In Edo State, for instance, you find that there are healthcare centers, but they are not functional. They are either dilapidated, or they can't just provide the kind of service they're supposed to provide. In fact, I was looking at data recently, and it said that only 20% functionality is present in healthcare centers across Nigeria. That is sad. Okay. So if you look at it, it means that completely prevention is not happening. Women get pregnant. They don't know that they're supposed to upscale their health. Just awareness talks that you could give them. Upscale health, improve diet. If you are diabetic, control it before you get pregnant. Things as simple as folic acid, people are not taking. Children are being born, neural tube defects. My husband sees a lot of hydrocephaly and all of that. Then you just find out that the simple things are not being done. Hemorrhage is killing a lot of our women. Malaria causes anemia, which is endemic to us. And by extension, anemia will also predispose a woman to reduce the size of the baby when the baby is growing, because there are no nutrients across the placenta bed. But again, at delivery, it predisposes to bleeding. So it's double whammy. You don't have enough blood and then you're predisposed to bleeding. So you find out that even just having an awareness drive at the grassroots in our different languages can curb a lot of unnecessary deaths. Again, look at human capacity for healthcare. How many, we shouldn't kid ourselves. A lot of doctors, healthcare workers, nurses, midwives are leaving resource-rich nations. They are leaving them for greener pastures. So we should kid ourselves not. But how do we manage in the interim? Because I see them going away as capacity building, and I know that eventually a lot of them will come back. But in the interim, when people are leaving because people are not being attracted to stay, the environment, how do we stop them from leaving, i.e., not to make that decision? It's by upscaling the facilities, the pay, the internet, the light. I was just telling you just now, there's no light. I'm in Nigeria currently. The light, how do we do all of that? And how do you ensure that people will stay even when you do all of that? So for me, looking at the sub-national governance of Edo State as a case study for Nigeria, what I've done is to carefully think with my team after doing some sort of root cause analysis and also going into the field to interview people. We've come up with thematic analysis that has revealed that we must domesticate the interventions we are going to take. And one of the key things is to actually ensure that basic healthcare and education is in the front burner, devoting capital to it, upscaling human capacity development, and I'll give you something that we have thought of as a prototype. When you go into the communities, let's use Edo State as an example, you find out that there are certain persons in that community, and I'm using obs and gynae. Now, traditional birth attendants abound, not just in Edo State, across Nigeria and across Africa. And in the UK, I'm sure you may have heard of doulas. They are sort of like the equivalent. Now, these people may not have formal medical training, but there's something we can do. We can train the trainers. We can train them. They will remain in those communities, and we teach them the signs and timings to refer, when to refer. And it's been trialed in other African countries. So what that means is we employ these TBAs, traditional birth attendants, the community health extension workers, and we train all of them through a national program or a state program, as the case may be, depending on what level we are working at. And we ensure that they understand something like, for instance, if a woman is in labor for so and so hours, optimally they say the sun does not set twice on a woman in labor. But we can investigate, and from my timeline, it should not be more than 12 hours. But you don't wait for that 12 hours. At the 8-hour mark, you teach them that they need to refer. They need to start planning how to send that woman to the nearest secondary healthcare center. And you must look at the terrain. Is it waterlogged? Is the road bad? Do you need tricycles to take these women instead of formal ambulances where the road is bad? Do you need speedboats? We must domesticate our interventions. And because these are people from the community who you have upscaled, they will stay. They are more likely to stay. And of course, you must develop amenities. Don't think, because there are people in the community, then you're not going. You must develop the amenities there, the light, the power. And solar power and alternative energy sources are going to come in very, very handy to make sure our primary healthcare centers are working. Now, when they refer these patients, you must find a little way to incentivize them. I'm not saying pay them. I'm telling us that we'll do something that sustains them. So you may say, for every 10 patients you refer for your practice, the government will probably do a rebate of maybe whatever fees you pay, charges you pay. Even maybe they will give you continued professional development lectures or courses for free. So there must be that thing that is tied to it that will make it sustainable. And you find that people will start remaining in the communities. So when you have more TBAs, more CHUs, more nurses, you are going to need less doctors. You're going to save more money, but you've built capacity for healthcare. And we must not forget that we can leverage on telemedicine and use our huge diaspora resource. I mean, Edo State is renowned for having people in the diaspora. In fact, the International Organization for Migration quoted that of about 60% of returnees from the diaspora, illegal returnees, were of Edo State origin. As much as they are illegal, they are also legal. So Edo State is the only state, I think, that Western Union sponsors our major festival, Igwe Festival. So there's a reason why they are doing this. It's because our people are out there and we contribute hugely. So why don't we leverage on these our theming diaspora and utilize them to actually make these basic things work? Why don't we exploit telemedicine? Somebody can be in San Francisco now and give guidance to someone in a village in Ososo in Edo State, or in a village Umbano in Igbo land. So these are things we need to leverage on. And then when people are bringing in imports for healthcare, it's something that Nigeria at the national level should look into. These things should all be subsidized, and the pathway for bringing them in must be made very easy. So these are a few things that we can do. And before you know it, when prevention is ongoing like this, it will be cheaper and wiser than cure. Our women will be better optimized before pregnancy. They will have an awareness and they'll feel better. And in the areas of drugs and medications, there's a simple magic drug that stems bleeding that can be used with the adequate training, misoprostol. It has been found to have changed management of hemorrhage, or bleeding when women deliver, and safely so. And it can be used in nations like ours where the temperature is very high. It can be stored at room temperature. What stops us from introducing this to all of these TBAs and actually getting them to understand how it's used, the numbers that is used, and what to do? Nothing actually stops us. And these are the things that my team and I have taught and we're going to put in place in Edo State. And other states in Nigeria can actually take from this masterpiece. Maternal mortality is so abysmal. It's such a sore spot for me because people are actually carrying out their physiological, natural duty, their reproductive duty, and they die at it. No. We need to up the ante for basic health care, education, and we should not forget girl-child education, and we need to allow the communities to own these projects. When they own these projects, let me give you a practical example. If I'm fixing a healthcare center in maybe Uoha in Edo State now, I need to first go to the local chief in that area, speak to them. You don't assume that you know what the people want. You let the people tell you what they want. And that process gives them ownership of what's going to happen. And then you now tell them, this is what we want to do, this is what we want to do. And they support you. They see it from scratch. They see you grow, and what you are going to do is that in the process, you are creating employment for them. In the process, they are going to own this. In the process, they are going to tell the people, change their healthcare seeking behavior and come to you. And at the end of the day, you are going to find out that you are going to reduce not just maternal mortality, but death rate across the board from different illnesses. So I don't want to embezzle our time on this particular subject matter, but it's very, very key, very dear to our hearts. And it's something that we should not let happen at all. So let's go there. and let's fix this. And when I keep talking about education, please, I just want those listening to me to understand that I'm talking about basic education. So primary education. Data has shown that when people have basic education, in the very least, their healthcare indices actually goes up as well. And for education, we need to focus on, after primary education, technical education. Technical education will increase our own production. It will also increase, even when you talk about healthcare centers, building this, these people will take charge of it. And you're also creating jobs by extension. So healthcare is linked into all the other sectors. There's no way you can separate it. Educate a woman, you educate a nation. Heal a nation, you increase productivity of that nation. And it's the same thing for subnational and state governance. So we need to take a cue from how people are devoted to the NHS, even though in the UK we all complain that the NHS is this, is that. I often tell people, you need to go somewhere else and have a comparison, and you will see that you are blessed with the NHS.
Wow, that is phenomenal. It isn't just listening to you talk about it. You can feel the passion, you can feel the energy, you can see the enthusiasm and the leadership that goes with it all. I had like some piles of questions I wanted to ask you, but the thing though is just you just like went through like all of them very seamlessly, which means like it's something that you like thought through, have already implemented some plans in place, shovel ready to go. So that's phenomenal because, like here in the UK, when a woman is pregnant, from what you're saying is, we need to have facilities where somebody tests positive for pregnant, even before they go into planning for baby, they would have like a preconception sort of like, chat, because at grass level, some people can meet this these TV folks that you're talking about, where they can go and have a little chat about, okay, we want to start having a baby. What are things we're supposed to put in place? Because that's what people do here in the UK. So people come to me in clinic and they go, we're trying to start family. What do we do? Right? And you mentioned about folic acid, which is tremendously important, because if that's incorporated within the primary care domain, then people will be able to get the nutrients that want, include from food, from traditional medicine, whichever way it goes. So all of these things are input. It's like as if you just read through the whole manual of like primary, secondary, tertiary care. And to be honest with you, I think if this is walkable and this is enforceable, I think he will put a do in. Thank you guys for listening today. I know time is of the essence, and one of the most important things that we definitely will take away from this, I want what you feel to be the passion. I'm not a politician. I don't get involved in politics as such, but when I know somebody to whom I have tremendous trust, tremendous respect for, and I know that most of the things, you see, one of the things with most of us abroad is usually we say, oh, I wish our country would be like this. I wish our country to be like so. But, who is going to do it, right? And when you see somebody like Dr. Loretta who goes, you know what, that's me. I want to be that ambassador. I want to go there and then put all the stuff that I learned overseas and bring it home. Even if it makes 1% change, that's the win. That's the aim here. So, and we're going to come up with more topics on the health related issues. And you can see, like, for once, she hasn't even mentioned anything about politics. That's one of the reasons why you can see her passion is all about making sure that her citizens get the care that they need, because the health of a nation is tremendously important. And in this sense, it does state. So thank you so much, Dr. Loretta, for your time. And we'll meet again so that we can talk about more and more topics on what would help people in your community. And I'm sure people will really appreciate that. So thank you so much.
Thank you very much, Dr. Amobi, and keep doing what you are doing. You are making an impact, you and your team. I mean, we cannot make any changes at a table. We cannot shake any table if we are not at that table. So you deciding to actually do this, sort of dovetail the UK, what happens, just oppose it in Nigeria and see how we can change things is fantastic. And yes, for the men and women out there listening to us, next episode, we will trace that pathway of how individuals in Nigeria, and of course, we focus on Edo State for me, men as well can actually trace that pathway of healthcare and what we can do differently. Thank you so much for having me.
No, thank you. Thank you so much.
For all our listeners out there who want to connect with Dr. Amobi, the best way to do that is on LinkedIn at Dr. Amobi. You know, Dr. Amobi is the Chief Medical Officer of 3 clinics. To find out more about the services he provides and how they can help you, please contact him through his team via the following websites: passporthealthuk.com, mymenopausegp.com, and the lifestylewellnessclinic.com. You can also follow Medicine in Small Doses on Instagram at Medicine in Small Doses. We look forward to you joining us on future episodes, and I want to thank you personally for listening.